But I think the reality is that we as humans are having a human experience, some of which is incredible and some of which is terrible. And to deny ourselves the opportunity to feel any of those emotions would be to deny our own human experience. And so processing feelings, and I think the bigger ones in particular, like grief, especially in the work that we do, it's not only good to do, but it's part of just what it means to, I think, be a human.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Ann Konkoly, CEO of Authentic Koaching, LLC, and Kultivate Women's Health, LLC, in Cleveland, Ohio, about processing grief in a healthcare context. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome, and thanks so much for joining us today, Ann.
Thank you for having me. I'm so happy to be here.
I think this is a really important topic, certainly for all nursing, maybe especially for oncology nursing. So I'm excited to talk with you today and just be able to share all of your knowledge and expertise to hopefully benefit the many nurses that I know listen to our podcast. So to start things off, we can start with the basics. What does it really mean to process grief?
I think this means different things to different people. And so the act of processing a feeling, and I love to talk about feelings. We'll talk about them a lot. We talked about it at the ONS Congress this year, and we'll talk about that. But processing is just what we do with these big feelings or these small feelings that come up and how we work through them. And it really depends on the individual and what coping tools and mechanisms that they use. But usually for a lot of people, what we see is that when there is some sort of feeling like grief that comes along, one of the most important things that we can do is just to, number one, acknowledge that we are having some sort of a feeling and to then subsequently name it. A lot of people feel a good amount of relief. We've got some good data to support that the act of just naming a feeling like grief can be therapeutic and can create some element of relief for the individual. Just to put a name to what the vibration and physical sensation that's going on, in his, her, their body. So if we acknowledge that there's something going on and then we subsequently name it, then from there, a lot of the approach that I use with my clients is using cognitive behavioral technique, which allows us to look and say, so what am I thinking that's causing this feeling in me? And then when I feel that way, because I'm thinking that way, and when I feel that way, what then do I do? What do I not do? And what does it look like if I were, sitting like a fly on the wall and observing myself? What would I see? And then from there, observing what results do those actions create? Does that create something that I desire or something that serves me? Or does it create something that really doesn't serve me? So that's a very technical way to look at it, I think. And then there's this other element of processing grief that I think most of us who have been through the process of loss and who have experienced grief, whether it's in a professional sense or a personal sense, would probably agree that there's no rhyme or reason to when grief shows up, and that the process of feeling grief and moving through the loss of someone in your life or a patient, that the process changes for each one of us and it's somewhat unpredictable. And so when we start thinking about, well, what does it mean to process grief? Well, I don't know. It does take on a different form for most people. And we have a lot of tools that we can use to become observant of it and to just see if we could step back from it, to take a 30,000 foot view of when I feel this way, what happens. But I'd say it's kind of one of those, it comes in waves and it means different things to different people and they do it in different ways. And so there's just no one right way.
That's so important. And as I'm listening to you already, I'm thinking, how does this apply to me, myself as a nurse? And then also looking to my teammates, in practice, on the unit, on the floor. If I see a teammate struggling, how can I use this information now to help, not like diagnose them, but like to maybe identify and try to kind of put myself in like maybe what they're going through or kind of maybe what part of this process that they're in potentially. So I just see multiple aspects. And of course, then also with patients or patients' caregivers and families, if they're dealing with grief. So I'm excited to hear more because I think that there's multiple ways that this can apply for nurses, for themselves, as well as their coworkers and the patients they care for. So let's talk a little bit about the importance of processing grief. Why is this important for nurses, especially nurses, because of how we see grief as part of maybe our daily routine, as part of our job?
So one of my coach talks about how we have this life and it's a 50-50 life. And 50% of the time it's good and amazing and awe-inducing and profound and joyful. And 50% of the time it is full of frustration and angst and rage and disappointment and discouragement and disgruntlement and negative emotions. And so I think that if you had said, well, why is processing grief important for nurses? I would say we could interchange grief with any feeling and just say, why is it important for us to process and feel and to name and label these emotions and become emotion scientists? Well, because it's part of the human experience. Not one of us gets out of here without having an experience of all the human emotions. And some of us have them multiple times in a day. I have a feelings wheel here that I just chuckle. I use this feelings wheel with all of my clients. They all know the wheel. I will tell them, wait, when we're in the process of saying, we're really observing what's going on, and we'll try to get granular on what is that feeling. And so we'll go through like a list of feelings on the wheel. And they kind of chuckle because when you're able to name it, it just really hits, right? It's that feeling of relief of like, yeah, that's what I feel. But I think the reality is that we as humans are having a human experience, some of which is incredible and some of which is terrible. And to deny ourselves the opportunity to feel any of those emotions would be to deny that, our own human experience. And so processing feelings, and I think the bigger ones in particular, like grief, especially in the work that we do, it's not only good to do, but it's part of just what it means to, I think, be a human, which is learning these tools to process and deal with things like grief and frustration when they come up, because they're bound to come. Because, again, if that premise is true, and I like to think it is, it's a 50-50 life. And the best that you and I and any of us can do is show up with some good tools to manage on, the days when it feels really hard.
Absolutely. It makes me think of like the signs and coffee mugs. They're like good vibes only. I'm like, no, all vibes are okay. They don't have to always be good. And that compulsion, I think sometimes we feel society makes us feel like, oh, put a smile on, make it okay. There are times and places where maybe that is temporarily helpful. But I think, as you've mentioned, it is important to allow yourself to process and to feel all of the emotions that come with life and life as a nurse, because as you said, they will come up, some more frequent than others, it may feel like. So being prepared and feeling like you have tools to work through any of those emotions is certainly going to be what helps facilitate, those good coping skills.
And I think people look to us for comfort and care and support. And so if you and I want to commit to our profession, that we show up, in full service of our patients, and that we show up in the best way that we can in service of them and their needs, because that's the work that we have agreed to do, whether it's contractually in the form of a contract that you've signed, or it's the values and kind of the way in which you show up to do the work. If you and I can agree that that's just part of the work that we do, then you and I then have to show up in a way that honors us as humans first, and we give ourselves the tools to be humans so that we can show up for that additional work of caring for the people who aren't in the families and who aren't in our communities and who aren't our neighbors, but the people that we're being paid to care for, right? So to me, it feels like it's not even an important thing to do. It's a vital thing to do for the profession, for the patients, and really for us as our, in terms of just being so compassionate to ourselves.
Absolutely. So we know that oncology nurses often form strong bonds with patients and families. Other nurses, other specialties do, especially when you're dealing with, these pivotal, life-altering, both good and bad, life-altering moments in a person's life related to healthcare. So we know oncology nurses have a very special experience in doing that. And those bonds can last over a long period of time, potentially. So how do those relationships affect a nurse and how they're able to process grief?
I think that for the work that we do, number one, even if we didn't have long-term relationships with patients, I think the nature of caregiving is such that it requires us to be present, and it requires us to be, to come in emotionally prepared, right, for all the things that could go on. And so I think when we start to look at the disciplines like oncology, where you may tend to have more relationships, just as I do when I was in my midwifery practice, and now in my practice as a nurse practitioner, I form relationships with patients. And that's part of what I love about healthcare. I have the opportunity to help them in a way that I can relate to them, and in a way that I can work with them, maybe over a 60-minute visit or a 75-minute visit. And so the nature of the game is that when you and I do that, when we commit to forming relationships, we invest in those relationships and we get involved in them. And some people would say, well, that's then the fault of the nurse, right? Maybe we shouldn't be so involved or committed or in our relationship, so to speak, with our patients, right? Of trust and, of caregiving. And I think from a professional sense, there's probably some truth and maybe legitimacy to that. But on the other side of it, we're still two humans. I'm providing a service and I'm helping somebody and showing up to do the work that I think is valuable and helping them to, have the results and create the experience that they want to create in terms of their health. And so it's only natural that we're going to be invested. And so when something like grief comes along, it's only natural that we will feel that probably to more of an extent and to a larger degree than we would with other emotions, or if we didn't have that relationship in place. And so I think the first part of it is acknowledging, yes, in fact, it's totally normal. It's totally normal to have a relationship with a patient of caregiving that is completely professional and that also cares for them in a very humanistic way. And it's totally appropriate for you and I to have feelings about the loss of a patient or the events, especially the unanticipated and undesired events that happen. The feelings that we have are completely and totally normal. Because again, if we are humans and if we agree that this is a 50-50 life, we're not getting out of here without experiencing all of these feelings, and we're going to have them at work and we're going to have them at home. And so again, the job is we just need to get a little bit better about what do we do when those emotions come up and when those feelings like grief really, feel heavy and hard. And they do, because they are heavy and hard. It's learning, I think, to take care of yourself when you feel those feelings, because they are going to come up. There's probably no nurse. We could probably survey 100 nurses and say, have you ever experienced grief from the loss of a patient or from an unanticipated event? And I would imagine, just by sheer anecdote, that 95+% of them would say, yes, absolutely. I've had an experience like that. So this is part of the game. And our job is to get good at using tools to support ourselves so that we can still continue to play the game and be a part of that caregiving situation.
Absolutely. It's the best part of the job is what makes this the hardest part of the job. Being able to create those relationships that span over time gives them great meaning. I think the typical response when you tell someone you're an oncology nurse, it's like, oh, that sounds sad and terrible. And then we always respond with, but no, we get this, we have these experiences and we get to take our patients and their families through this process and be there. And so that's why we do it. But then because of that, on the other side, when things do unfortunately have a bad outcome, then we have to be able to be prepared to help ourselves through that grief. And, I also think about nursing school and brand new nurses in oncology even. And, I have no data to support this, but anecdotally, it's like initially you are so focused on just learning how to do the work, whether it's task oriented, making sure, you remembered all those questions from the NCLEX and just trying to make it click and make it make sense. And so it's hard, I think, for new nurses in practice to necessarily have even space in their brains to focus on this piece of the work. But it is an important piece. And so I think it's okay if it can't always be front and center, but at some point, and hopefully it happens after maybe a couple of years through that novice to expert kind of continuum, that as the nurse becomes more comfortable and confident in their own skills as a nurse, they don't forget to reinvest in themselves, to become confident in their skills and their ability to help themselves through these types of grief episodes.
Part of it is the culture that we're in, which is a culture that really has put a cap on. And I think, I'll share my own experience, which is that I've cried at plenty of babies being born. I've caught 700 or 800 babies in my career. And I've shed many a tear, because if you've been in a birth, it's a beautiful, a lot of the time it's really just this very profound moment, and still even to think of it, some of these births that I've been attended, there were just these beautiful moments. And I can't say that all of my colleagues approach it that way or that they have had maybe the same experience. And even just saying it, I'm a little nervous even to just say that out loud, because this idea of crying at a birth, because it's knowing full well that in our profession, we often don't have time or the luxury of being human in a very human profession, a human-centered profession. And so there's some of it, which is that, yes, as we're getting going and learning, getting our reps in as nurses and NPs and figuring out all of the task-oriented things of how to do this, that, and the other thing, of course, it's normal that our brains go to, well, let me make sure I do everything right or do it to the best of my ability so I'm not hurting anybody, right? But the other piece of that is that we are also brought up in a culture which I don't think gives us much space to do that sort of processing, and we don't talk about it. And so when we are faced with some of these moments, which happen in our careers, where again, it's a feeling like grief or some sort of a, again, unanticipated and undesired outcome, sometimes I think most of us wonder what to do with it and are given this recommendation of, well, you just have to keep going because that's what people do in healthcare. I think the other piece of it as a culture, we have the opportunity to be more humanistic in the way that we show up to work and the way that we treat our coworkers and the ways in which we make it okay to be humans doing this work. That's a huge culture shift. And I don't know if I'll see it in my career. I certainly hope that I do, but that's, I think, a part of it too.
Absolutely. So you mentioned as part of kind of coping and trying to process grief that there are some things that may be sort of easy to do or maybe commonly used and they feel good in the short term, but in the long term, perhaps they don't benefit us the way we think they will. So can you talk a little bit about some of those behaviors that people commonly use to cope with grief that really can be detrimental and that can have negative impacts long term?
Here's what happens. And I think to answer this question, we talked about this at the ONS Congress talk, which is this idea that when we are faced with a feeling and I would consider grief kind of a big negative emotion. And so when we're faced with a feeling like that, usually what happens is that the part of our brain that's responsible for the emotional decision-making center of the brain, or the limbic system, which is our prehistoric lizard brain, right? This is the brain that helped us run fast when we saw a tiger on the savannah, and it helped us to forage berries and make sure that we had ample access to food so that we didn't starve to death, right? An important system from an evolutionary standpoint, an important part of the brain. But the brain usually, the limbic system is driven by these three main things that it wants you to do at all times. It wants you to seek pleasure, number one. Number two, it wants you to avoid pain. And number three, it wants you to conserve energy. And again, if you start to think about it, if I'm on the savannah and I am, in a small tribe, I don't want to upset the people around me and get kicked out of the tribe and then have to face the savannah on my own. I want to run fast when the saber-tooth tiger is coming. And I want to make sure that I don't expend a ton of my energy so that if the saber-tooth tiger comes, I have plenty of energy to run. And so from an evolutionary standpoint, totally makes sense that when faced with a feeling like grief, most of us say, oh, well, the limbic system drives us to say, let's avoid all that pain, because that feels really heavy and hard and it's going to take a lot of energy. And so many of us, from a purely, as a human approach to things that cause pain, we usually turn away from them. And it's totally normal. Nothing's gone wrong. That's how the brain is designed. But what tends to happen is that when we don't allow feelings and we don't learn how to process emotions and feelings like grief, what happens is that we usually then resort to other things that help us feel good in the moment. And we call this in coaching, this is a term that's called buffering, where when you buffer, you go to an external substance or source in order to make you feel better, rather than doing the work internally to create the scenario where you process the feeling and, move through it. And so what I most commonly see, and this is not only in my own experience, but in a lot of the work that I do, is that many of us with negative emotions, we go to things like food, we go to the pantry for cookies, or chips, we use alcohol, some do gummies. We see people who just go to social media, who go to Netflix, who just want to get under the covers with the chocolate and a glass of wine, pull the covers over and just avoid and totally hide. And the limbic system loves that. I mean, the brain, again, you have to, right? If we look at it from an evolutionary standpoint, the brain is like, this is fantastic. This is exactly what we want to do with this big emotion. But what we also know is that over time, we have developed a prefrontal cortex. And so our prefrontal cortex is the part of our brain that is very knowledgeable. It's logical. It helps us with analytics and logical decision making. And it helps us make decisions from a space of our future selves rather than, what does the version of me want? If I eat cookies today, tomorrow, and, every day after, will I have the body or feel as good as I do in my body with eating those Oreos as I would if I didn't eat them, right? So the prefrontal cortex chimes in and says, wait a minute, that actually may not be a good idea. Maybe we don't want to do that. So for all of us who are humans, we are having an interplay of these two systems all day long. The limbic system, which again is like, no, we don't want to deal with grief. That sounds way too tough. And then our prefrontal cortex, which says, wait a minute, actually, we don't need to go to cookies or Netflix or wine, every night just to avoid this. We could do some other things that are maybe going to serve us a little bit better so that we don't, have an increase in the liver enzymes, or we don't see our weight increase, or we don't then not, invest in our relationships, the ones that really help us feel good. But many of my clients I see, and again, this is for me too, buffering is a method that in the short term gives us a great dopamine hit. It feels really good to have the cookies when you're stressed out or when you first come home from work. And again, that constant utilization of an external source, it gives us usually the scenario where, well, if I come home and have a glass of wine and my Oreos, and I do that again I work 5 nights a week and I come home and do that 5 nights a week. And then all of a sudden I start to see the scale go up. Am I okay with that result? Am I okay with being that person? Or when my kids come to me and say, Mom, what's for dinner? And all I want to do is just yell at them because I just don't know. And if somebody asks me one more question, I might just lose it. And so I'm just going to have my cookies and my wine and just give me a minute. It's using these external things. And so that's where I think some of us get into trouble, because we start to see, oh, I just yelled at my kids and over here, having a glass of wine, trying to just keep it together through the end of the night. And it's totally normal. This is a very normal response. Our job always is again, to say, well, wait a minute, to get curious. What's going on? What am I thinking? What am I feeling? Can I name it? And what am I willing to do for myself from a place of compassion toward myself to allow myself to feel those emotions and allow them to be there and to process them without having to rely on some external source, which, down the road, if I do it again and again, usually has a great short-term dopamine hit, but long-term doesn't give me the results that I want.
I really appreciate all of that. What I hear and what hopefully others are hearing too is that it's not a moral failing. It's not a willpower issue. It's not a moral, like you've made this choice. Like it is driven by those impulses that are trying to be protective and achieve that in the short term. But as you said, like there are things that maybe are helping it. And I would say, occasionally like this is going to be the response and that is okay. But when it's every day, all day, week after week, month after month, that's when the accumulation of choosing that option as the only means to kind of buffer against some of those feelings, that's when it becomes problematic. And I also appreciate you mentioned kind of in passing stress. So a lot of this, there's overlap here. Grief is what we're focused on today, but we know that just being a nurse is stressful. And so a lot of the things that you're talking to us and teaching us today really, I think, have that dual application to just the general stress of nursing, as well as when we're processing grief from that work.
I can't stress it enough, but it is like, I love that you said it's not a moral failing, because it's not. This is just a human response. And what I try to teach my clients is, look, I sometimes like to have a glass of wine at the end of a stressful day, and I'm not opposed to it, but I do it consciously. I go into it and I say, I know I feel stress. I know I'm dealing with some whatever big emotions, frustration, disappointment, grief, what have you. I know that I've got those, and I'm going to make some time and carve up some space for those. And right now, in the moment, I'm going to have a glass of wine and I'm okay with it. And to do it consciously, like that's the whole, I think, part that is so powerful, because then we get to choose and we can say, okay, well, I get it. And I'm going to make the time and make the space, and, and nothing's gone wrong here. And I'm going to comfort myself in a way. Right now, it's going to give me a short dopamine hit and I'm going to feel good, and that's all right. And I know I've still got my work to do, and that's okay too.
So let's talk a little bit about maybe warning signs that nurses might be able to watch for in themselves, maybe in their colleagues, just to notice if they are experiencing grief, and so that they can hopefully identify it early and maybe not fall into some of those long-term detrimental behaviors that are used for that short-term relief.
Number one, it's a little bit about knowing yourself and how you react when feelings get big. And I think a similar experience for me with stress, grief, most of the negative emotions, which is that usually when they hit, if I can observe, oh, okay, this is going on, and I can see it, I can be an observer of what kind of how I'm operating within the world, like look at myself as if I were, 10 feet away, just observing myself. I think what's interesting is that if you and I can do that, if we can step back and see how we're operating, it gives us a little bit of a different lens, number one. I think the other piece is that when we can't see it ourselves, then the next step is to say, well, who else can I go to, who I trust, and who I may initially get a little bit frustrated with or defensive, too, but who I trust to tell me if I am operating out of a place, out of integrity with who I am, or out of a place that goes against my values. And so for many of us, this is where you start to see where, a coworker will come in and you'll say like, oh, hey, how you doing? And they don't respond to you quite in the way that, they usually do. Or someone will say, or when you go home and your partner says to you, boy, I don't know what's going on, but you're just not yourself. And when the people who I think are closest to us start to say those things, or they notice, or we ask for the feedback and they give it to us the truthful way, and they're like, I don't know what is going on with you, but you're like at 100 and we're down here at 10. That's the piece where you have to be willing to look at that and come at it from an objective standpoint without judgment and without bias and without criticism of yourself, but to say, oh, wait a minute, maybe there is something that I'm not attending to that needs my attention. And what is that? And then to again, get curious. And, and sometimes this is for most of us, this isn't work that we're very used to doing, because if you grew up in a household like I did, we didn't talk about feelings. It wasn't a part of, and this is a curriculum, when I teach my clients, we have a book that we use called Mark Brackett's Permission to Feel. It's a fantastic book and I love it. Mark Brackett talks about a curriculum that he's designed to take into schools in order to teach kids how to have an emotional language and how to be emotionally and socially regulated. And I just think I never got that kind of training. You know what I mean? I hired a coach. I got training as a life coach. And that's when I learned emotional and social language and regulation. And I'm somewhat embarrassed to say that, but that is the absolute truth. And so if you find that you are, for those of us out there who find we're somewhat ill-equipped and our partners or our colleagues are saying, boy, what's going on? And we don't know, the next step is to say, well, wait a minute, who can help me kind of figure this out? And I think whether it's therapy, whether it's a coach, whether it's a trusted mentor or colleague that you could have a very honest conversation with, whether it's your employee assistance program that, provides you with some resources and support. There's no right or wrong way to go about it. But at some point, if you recognize that you can't quite either put your finger on it or you have feedback that, you're not your usual self, I think that's when it's time to reach out for help and say, maybe somebody else can help me kind of work through and explore, and with love and curiosity, kind of what's going on for me in a way that's going to help me figure it out.
The ability to do this work, to process these emotions, it's not innate for everyone. I think some people maybe have an easier pathway to this, or maybe are more inclined naturally to do this. This is a skill, I think. Like everything else that we do in nursing, we had to learn it at some point. And so if you did not learn this as part of your upbringing or your childhood, or did not have an experience that, taught you some of these skills for some other reason, then it is important. It can and it probably should require some sort of dedicated, intentional learning to develop these skills. Because as you said, they're not just going to be helpful in nursing, though certainly they will be. It's in life, and being able to do this work will bleed over into all of our areas of life. But obviously in this context, in our work as a nurse, and being able to be there and be present for our patients in a way that helps enrich their experience of the care that we provide.
Yeah. And that also allows us to have a great experience of being a nurse. I mean, we always talk about, oh, this is so beneficial to the patients. And it is. I mean, it's really good for us to be emotionally regulated when we come to work. It is really good, because if you're in the parking lot and you've ever spilled coffee on yourself and you want to literally die of embarrassment because you're walking in with coffee spilled down your front shirt, or you are angry at yourself because, you really wanted that cup of coffee, the skill of being emotionally regulated is really powerful, so that when you walk into your patient's room, you are calm and you are keeping it together, right? In a way that helps you do the work that you've been trained and contracted to do. This isn't part of the training, I think, that most of us get, and that there's nothing to be ashamed of. And this is, I think, the work that most of us would think of as an add-on. And I would say this is a requirement for, if you want to be somebody who lasts in a caregiving profession, then you must learn to manage your mind. You must learn to be able to be an emotion scientist and to be emotionally regulated. Because if you don't, you will subsequently most likely end up burnt out. and so burnt out that you're crispy, as one of my clients has said in the past. And that's a lot of where I see my clients come in. They've gone through situations, they've gone through the patient losses, they've gone through dealing with the systems and all of the frustrations that come with it, and the charting a million things. And they're frustrated and they're upset and they're sad and they're angry and they're burnt out. And so I think that's the key, is that, it's good for the patients. Most certainly. Yes, of course. But what do we need for us as a profession to maintain our ability to give in a way that serves us and that serves our ability to be present and to have a great experience of professional work in this profession that we've chosen?
Now that we've described, maybe some of the negative behaviors that are normal and commonly used to help buffer some of these emotions, can you describe maybe a few? I know there's probably many, but can you highlight maybe a few strategies that nurses might use to process their grief in a positive way?
We talked a little bit about cognitive behavioral technique, and that's one that I use with my clients. And I think for many of us who have maybe a more logical brain and we like to see things in a formulaic approach, that is a great technique. The other one I love is Tara Brach. She has a technique that's called the RAIN technique. And it's really super simple. It's just a 4-step process. When you feel a feeling come up like grief, it's just number 1, recognize that something's going on, that there's a vibration in your body. Number 2, allow it to be there without having to change it, without having to avoid it, without telling yourself you're a terrible person or, feeling bad about it. Then I is to investigate with care and to just ask yourself, again, this is using this principle of curiosity, what's going on that I'm feeling that way? And then this last piece of nurturing. And I love this piece and I love this technique because it's got this last piece of the N stands for nurturing, which is this idea of how can you, in a radical act of self-love, how can you comfort yourself and love yourself through that process? And I love that because so much of the work that we do on a cognitive level, again, it's more of a formula and it's more data driven, right? I can see that this causes this and this causes this. I love the RAIN technique because I think she adds in that piece of just this, how do you nurture yourself when you are having a feeling like grief? What kind of person do you want to be? And how do you want to respond when you are confronted with a feeling like that? So those are 2 big ones. I think the other one, we got a lot of data on journaling, which is a great tool that I think for some people love it. Some people can't stand it. Some of my clients get that as homework and they can't stand it. That's totally fine. It's like the question of how do we process grief? Well, I don't know. It's a little bit different for everybody. It's the same thing with what are some of the things that we can use to help us? It's really a practice of figuring out what works for you. Some people, it's going to be the act of journaling and taking everything that's in their brain and writing it down and without discrimination and without judgment and just getting it out, like doing a thought download on paper and getting it out from the brain space onto a piece of paper that you could subsequently burn, tear up, crumple up, throw out, do whatever you want with. But we have good data on that. And then I think the other piece I talked a little bit about was Mark Brackett, which is this idea of becoming an emotion scientist. And again, using this premise of curiosity to really name what is the feeling that's going on right now. Because again, we have good data to say just the act of naming a feeling can be so helpful it can decrease our symptoms of that emotion by about 50%, which is crazy. Just from naming it, just from acknowledging that there's a vibration there in your body and then naming it as like, oh, that vibration, that feeling that I have in my body, that equates to grief or shame or discouragements. And then I think there's all sorts of, there's yoga and lifting weights and walking. Walking's been a huge way to process for me as it is for a lot of people. It certainly is good for cardiovascular health, but the process of moving your body and pounding pavement, I don't know for most people, but for me, that feels really therapeutic. And so it's a regular part of my routine and often something I recommend to clients. Again, I think it's finding whatever works for you in a way that serves you and it serves your body and it allows you to process and it doesn't have something negative associated with on the back end, like where, something like wine or Oreos or Netflix or social media, may have a negative repercussion on the back end of doing it again and again. But it's just kind of finding what feels good to me in my body and what feels really nurturing and compassionate and what works for me based on how my brain works and how it deals and processes these feelings.
Absolutely. And as you said, there's no right or wrong option necessarily. Everyone might need something different. And you had referenced earlier, just doing these things with intention. So being mindful of, if I'm going to try this intervention to see how it affects how I feel or my grief and how I'm processing that, being able to, again, we like to, as nurses, we're sometimes very scientific. We want to be able to connect those dots. And so being mindful of that and being able to connect like, oh, I did this and I do feel better, or this is how I feel now. And again, just trying to kind of hardwire some of these techniques into your sort of toolbox of how to help cope with some of these strong feelings and emotions. So let's pivot a little bit. Describe your self-coaching model and what it enables nurses to do. And how did you sort of introduce this model to nurses that you work with?
So the self-coaching model is essentially, the base of it is cognitive behavioral technique. The self-coaching model was designed by Brooke Castillo of the Life Coach School. And so the model is this. It's a little bit different than cognitive behavioral technique. And those who are familiar will understand this, that with cognitive behavioral technique, we say, well, your thoughts create your feelings and your feelings create your actions, and then your actions create the result. That's what we would see with the self-coaching model. In traditional CBT or cognitive behavioral technique, we have three components, which are my thoughts create my feelings create my actions. And then there's this loop, that kind of continuous loop that goes on. And those actions that I create will create new thoughts, and those will create new feelings and new actions, and so on and so forth. But with the self-coaching model, I really like it because it also adds in this element of what are called circumstances, which is this level of objective data. And so I think this works for our brains as nurses. It certainly works for mine, which is to look out in the world and say, okay, there's objective data that exists in the world, and I then subsequently have thoughts about it. And I use this example all the time, which is that when I was on shift as a midwife, we had one central board and we would give a report off that board. And on every Wednesday, we had two midwives come on, and I'd stand next to my midwife colleague and we would look at the board and what stage of labor the patient was in, and, who had who, how full we were, how many beds were taken up in triage. And both of us would have a different experience of that board. One of us might look at it and be like, oh Lord, this is going to be a heck of a day, And one of us might look at it. And I used to have a colleague I work with. She was fantastic. And she would she was ready to go. She had the energy of 5 people and she just loved it. She loved the chaos and the movement of triage. And she wanted to get the people in and out. And she was great at what she did. I can't say that every day I showed up to work with the same thinking, but here's the thing, we would stand there in front of this board and we would look at it and she would look at it and be like, let's get to work. Come on, let's go. And I would look at it and be like, oh gosh, this is, wow, we're really going to get pummeled today. So that's what in the self-coaching model, we know that there's this data, objective data, arguable in a court of law. It's neutral. And in this case, it would be the board, right? This would be their circumstance. And then I would have my thoughts about it and my colleague, she would have her thoughts about it. And my thoughts would create certain feelings in me of like, oh boy. And then I would kind of, I'd maybe want to sit there and drink my coffee a little longer before I got going. Or maybe I wanted to avoid seeing the attending because I was going to have to figure out what to do on this really complex patient. And she would have her kind of whatever was going on in her brain, her thoughts, creating her feelings and her actions and her subsequent results. And so I think the self-coaching model is so powerful because, again, it gives you a way to take what we see happen, right? Again, to observe it, to put it on paper, and then to say, oh, what's the circumstance going on? Oh, we both saw the board. Oh, I saw the board and there's 10 patients on it. And my thoughts, this is going to be a terrible day. My feeling about that, annoyance, frustration, anger. I mean, pick whichever feeling aligns with you. And then when I feel frustrated, showing up at 07 to shift, how do I start my shift? Well, I might be a little bit more gruff. I might not be saying good morning, everybody. I might not be so excited to be there. And then I might not start my day off, on the right foot. And I might drag my feet a little bit going into that first room to see the first patient. And what's the result that I create? Well, I usually create kind of a crummy day for myself because I'm like moping around thinking about how hard it is. And so with the self-coaching model, it becomes very easy to see, oh, interesting. And it becomes very easy, especially when you have another colleague standing next to you who's like, let's go, let's get to work. And she is just off to the races. And man, you'd think she'd had 5 cups of coffee and she's got some secret sauce that she's hoarding and that she has every time before she comes on shift. And you think, well, what? Can I get some? And,
right.
But she's thinking about it differently and her mindset is very different. So she creates a different result. She goes about that day and she wins. And I kind of go about that day and I'm like, ooh. So I love that. I love the model, and to be able to self-coach is to be able to become an observer and to see that happen, and then to take this formula, so to speak, and to really plot it out on paper. For some of us, it's a really helpful exercise to understand, oh, if I were a fly on the wall and could see when I think this is ultimately the result that I create. And is that the shift I want to have? And that's where it really becomes, the opportunity is really right. Because, if I go to work, if I work 1 to 2 call shifts a week and, I do that for 3 years, at the end of 3 years, I'm not going to really probably want, or the end of 2 years or 18 months, I might not want to come back to work. I may start getting Sunday scaries and be like, oh, it's going to be so hard tomorrow. So I get to look at that and say, okay, well then, do I want to think differently about this neutral circumstance? Do I want to think like my colleague thinks? Do I want to think that I'm going to win the day and I'm going to go out and be the best midwife and I'm going to put my proverbial my cape on and I'm going to get out there and do the work and I'm going to have an incredible time doing it? And I mean, we've all worked with people like this. I mean, think about it. And you're like, what are they doing? They just love it. And you're like, I'm not having that experience.
What's wrong with it?
Right. And you're like, what's going on? And that I think the self-coaching model allows us to see, oh, this is probably what she's thinking and subsequent what she's feeling, what she's doing, and the result that's creating. And that's her result. And my result is this. And does that serve me? I don't have to change. I don't have to come up and show up to shift like this other gal. That's not the point. The point is to say, does the way that I currently show up, what I'm thinking and feeling, does that contribute to the kind of midwife I want to be, kind of nurse I want to be? And that's, I think, that's where the opportunity is. Because then you get to say, well, if not, then what do I want to do differently? And what am I willing to think? And am I willing to manage my mind and train my brain so that, I can show up in a way that serves my patients, it serves me, and it serves the profession and the work that we do, which is incredible.
I love that. And one of the last things you just said was that, it is a bit of a training, right? It's not as though you will forever have to intentionally walk through every step of that model to get to the end point where you make that decision. If you do it enough times, then it sort of becomes integrated into your natural thought process. And so it doesn't feel like this extra step, this extra process that you have to work through. It starts to become ingrained in sort of a normal way that you approach anything in life of doing that evaluation. And as you said, there's a little nugget, there's a little time in there where it is a choice. There is a choice to be made, which is, I like the idea of choices, right? If it was a model that made you do something, made you feel a certain way, like that wouldn't work. So I really appreciate how you described that and how this could be implemented for nurses, as you said, or just in your everyday life. So talk to me a little bit about some of the outcomes that you've observed as you've taught this self-coaching model to nurses, or maybe share some experiences or testimonies of nurses that you've worked with that have really found success.
It's funny. Most people come to me and they want to start a private practice or they want to get out. They want to get out because they feel really burnt out and they feel really stuck. And one of the main things, and they don't like this, but one of the main things that I try to help them see is that, look, if we are talking about these neutral things that exist in the world, like your job, it's a neutral circumstance. You get to choose what you want to think about it. And, subsequently, I would recommend that you choose something that serves you, because if you don't, you're just going to have a terrible experience of it and you'll be, terribly burnt out. But they often come is wanting a change. They want something different. They want to go into a different circumstance, which is fine. And, sometimes that does make sense. And sometimes that's a right move. But a lot of the work that I tend to do is getting comfortable and training your brain, just as you were talking about, with, are you willing to train your brain to see it differently and to make it work for you and to find a way that it can work for you and that you can think differently and that you can change your mindset? Because if you can do that, if you can learn to allow your feelings to come up and to process them like grief when they come, if you can observe what you do in certain situations and what you don't do, if you are willing to do that, you could go anywhere and do anything. And so many of my clients, I think, who come along, whether they are, they come probably thinking, well, I got to get out and I've got to, go work somewhere else or, figure out a new, something to do, or, what are the career alternatives for nurses, right? Like people Google that all the time. I used to Google that when I was terribly burnt out, and many of my clients do too. But our work is to say, wait a minute, if I wanted to stay, if I did, am I willing to think about this a little bit differently? And how much of that is in my control? And where do I have choice? And where can I exert the control that I do have, as an autonomous individual? So my clients come and they start private practices and they sometimes stay in their jobs. They sometimes leave marriages, and they sometimes leave managers, and they sometimes get married, and they sometimes stop doing things like drinking, and they sometimes get over using Oreos as a way to cope. There's all sorts of these very interesting things that happen when we start to, number one, get curious. Number two, just be compassionate to going through the human experience and being in a caregiving profession. And number three, get more aware of what we're doing and what we're not doing and why we're doing those things and not doing those things. So I see people, I take the small wins, for the client who comes and says, oh, I got to see patients in a 60-minute visit because I built a private practice. And now I'm doing it the way that I want to do it. That feels incredible. And to the patient who says, I was able to sit with my patient today and my patient was really upset. And I was able to sit with peace and calm in my heart and to allow her to have her experience and to grieve and to be there and to be present and witness. And I think that's a huge win too. The wins they're big, they're small, they're everywhere in between, and all of them are incredible. But this work is so fun.
That's wonderful. Thank you for sharing those examples. So you had mentioned earlier that you recently presented on this topic at our latest ONS Congress with Kyle Stimpert. And she shared her self-coaching model and how it helped her. So can you give us a brief overview of how Kyle used it in her life?
Yeah. So what we talked about during that presentation was that Kyle had gone through an experience of losing a patient, or a patient had died. And it was a patient that she was maybe not anticipating that death. And she said it really rocked her and it really left her with a lot of big feelings, and grief was one of them. And over the course of a year or two, she found that she wasn't herself. She felt on edge. She wasn't showing up for her colleagues the way she wanted to. She felt annoyed with some of her colleagues because of how she was feeling. And so we worked together to really give her the opportunity to use the self-coaching model and to help her figure out some ways to name that feeling of grief, and then to be an observer of what was going on when she felt that way, and giving her some of that autonomy back to say, okay, this is what's going on. Do I like the result that it's creating? Does it serve me? Or do I need to do something differently? And ultimately, what Kyle shared in that presentation was that she found huge benefit in learning how to, understand this process of what the thought was, what the feeling that was being created from it, the actions that she was taking and the result that it was creating, and how useful it was for her. And really kind of how it changed her perspective, not only on, her own personal experience of being a nurse practitioner, but the idea of how we cope and kind of what we all sometimes privately go through when we don't share it, amongst our colleagues and coworkers. And so she's a great example of how to develop emotional intelligence and self-awareness using a tool like this, like the self-coaching model, so that if you start to see like, wow, my relationships don't feel as good as they once were, and I'm not happy, I don't feel good at work, like I just don't feel right. And then essentially changing that around to using some tools to all of a sudden say, wow, I feel better. I'm not perfect. And I still go, she would admit to this day that she goes through her moments just as I do, just as any human does, right? Even if we learn all the tools, even if we're like, wow, I'm really good at using this tool. Some days, you're just not great at using it. And that's okay. We're not here to judge it. But what we know is that, man, it's a different experience. And I think she would agree she has a different experience of the world now and how she shows up in it now based on all the work that she's done versus before she did this work and before she committed to being curious, intentional, inquisitive, and aware.
And yeah, I think you touched on a really important point about not being afraid to talk about it and not feeling like this is some sort of hush hush thing that we can't bring up because it might make us feel uncomfortable or others feel uncomfortable. I think the more that just in nursing in general, in oncology nursing specifically, we allow these types of discussions to happen and be able to say it out loud that we're feeling certain ways, I think will also lend itself to encouraging nurses to take that step back and use some of these tools, develop the skill to use some of these tools so that they can support themselves, support others. Because as you said, we have to be able to talk about it and we have to not be afraid to admit when we're not feeling our best and start to explore that and dig a little bit deeper. And thank you so much for all of the great information that you shared today. I know I certainly learned a lot. I think this will be a very valuable episode for all of our listeners. So as we approach the end of our episode, we do like to run through a few quick fire questions just to help summarize some of the great points that you brought out. So to start that, how do you think healthcare professionals should evaluate maybe their hidden or implicit bias about processing and dealing with grief?
Do a burnout inventory and get a feelings wheel and go through it and see, do I know what each of these different feelings feel like in my body? Do I know kind of what the differences are? Or I think that's get some data around it. And Brene Brown has a wonderful, it's like an encyclopedia of feelings, the Atlas of the Heart. It's a fantastic book. It's a beautiful thing, right? Really test your emotional intelligence and your emotional language and go look up. We Google definitions of grief and disgust versus disdain. Right? Like if you don't know the definitions of those, look them up and give yourself the opportunity to be a student of learning those emotions. I mean, it's a great way to get out of your own way and to avoid some of your own bias, which most of us would be like, oh, well, I don't need to do that work or I don't have time to do that.
Wonderful. I have that book on my nightstand and makes me want to get it back out now.
Mm-hmm.
What are some common misconceptions about how people process grief?
One I hear the most is, she just needs to have a good cry, or just have a good cry and you'll feel better. And, sometimes a good cry will do it and sometimes it doesn't. The reality is there's no right or wrong way to process feelings, and it's going to look a little different for each one of us. And the goal for each one of us is to figure out, what am I willing to do for myself to comfort and support myself when I do feel that? And if I'm committed to being an emotionally aware and having a degree of emotional intelligence and subsequent emotional resilience, then how do I want to show up for myself when I do experience feelings like grief or frustration or, the negative emotions?
What's something about this topic that's not often discussed, but you wish people knew more about?
That it's easy. This isn't the things we do in healthcare are hard. Dealing with patients with cancer, that's hard. Dealing with a shoulder dystocia in the midst of a labor and birth, that's hard. Learning how to name your feelings, not hard. You know what I mean? Like,
you can do hard things.
Yes, I agree. And I always tell my patients, I'm like, look, or my clients and my patients too at this point, you have to look at what you've done in your career, which is that we've all signed up for some degree of schooling, education, clinicals, being preceptors. Like, we did all that and that was hard work and we got through it. And no one guaranteed us at the end of that we would have jobs, that we would be hired, but we all did it because we wanted to, or because we had some compelling reason to do it. And so when you look at something like emotional intelligence, which most people would brush off and say, that's whatever, maybe I'll get around to it. Or, if that's the thought, that's okay. But I think just acknowledge that there is value from a standpoint of having a human experience. There's value in caring for yourself in a way that helps you to be emotionally resilient. And I think that's the work that when we start to do, it's easy, relatively speaking, once you get the hang of it, number one. And number two, the impact, Kyle talked about this in the presentation, which is that the impact, the ripple effect of that is huge. Because when I start to be more self-aware and emotionally intelligent, I am a better leader. I care for my patients better. When I show up that way and I am less burnt out, my patient satisfaction scores go up. I mean, we've got good safety data to say outcomes improve when we show up with less burnout. So people would say, oh, that's too hard. It takes too long. It doesn't. It's not hard, but you have to be willing. And I would say it's very worth it.
What additional training or education do oncology nurses need to stay current in this topic?
Oh, I think there's some great podcasts. I mean, I've got a podcast that we talk about feelings all the time and just working through, it's called Nurses Living the Good Life. The Life Coach School podcast is great. I love Brene Brown. She is a social worker by training, but has such a nuanced approach to feelings and to especially the feelings of shame and vulnerability. And so she's an incredible resource. Mark Brackett and his book, Permission to Feel, is, I think, an incredible resource. There are therapists and coaches, and there are so many people who are out there doing this work. And I think it doesn't take much to find them. Carl Lowenthal, she just came out with a book called Take Back Your Brain. She's a fantastic feminist coach. Love her. There are so many options. And I think it doesn't take much to really find one. And if you're interested in this kind of work, know that there are plenty of resources out there. And the ones that I've listed are top notch in terms of the ones that I use on a day-to-day basis.
That's just great. I really appreciate those resources. And we'll certainly try to link as many of those as we can in our episode notes for today's podcast. Again, Anne, thank you. This has been just a wonderful conversation. I think a really timely and important topic for oncology nurses to think about and invest in themselves in to help address if this is something that they're struggling with right now, dealing with grief, as we talked about, dealing with other stressors, any emotion that's happening in life. So I'm so glad that we had you here today, and I really appreciate your time and your expertise. But do you have any final comments to share with our listeners today?
I just want to say thank you for all the nurses who are out there who are showing up and who are caring for people and doing it with sometimes, not all the resources that would serve them best in those roles, but it's incredible work, and don't ever underestimate it. And thank you for what you do.
Thank you so much.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.